Dr. Kariem Elboghdadly, how are you?
I'm good, Amit. How are you?
I'm very good. As you can tell, I'm in a mystery location, which our viewers will have to guess later. And it's really fantastic that you're joining us today to talk about RUK 21. So the first
Yeah,
question,
super psyched about it.
super excited, and so am I. And what's amazing is we're colleagues, so we're representing guys at St Thomas's as we head to that meeting, which is fantastic. The first question is, why are you looking forward to RUK 21?
I mean, there's about a million and one reasons why I'm looking forward to it, but for me, the biggest reason is, for me personally, is it's an opportunity to catch up with people that I really miss. Not you, but the others, of course, because I'm. But I'm really looking forward to catching up with some of the world's most eminent thinkers in regional anesthesia, what some of the best clinicians in regional anesthesia globally, and to get my academic juices flowing, to start to think about where we're going to be going with regional anesthesia, start to develop ideas, and start to build those conversations again that have been so subdued for the last actually almost exactly 1 year. So I'm super excited about getting regional anesthesia really raised on that platform again after this horrific train wreck of a year.
Well, that's a very compelling argument. And in conjunction with that, why do you think we should get our colleagues and our friends to sign up and register for the meeting?
So I think that what we've seen in this last year is as with most pandemics, everything just kind of exponentially increased, including the number of virtual events and number of virtual meetings, virtual conferences, et cetera, et cetera. Um, and one of the things that I've found over the last year is that things have gotten a little bit static in terms of novel ideas and novel concepts in virtual meetings, which is why I don't know if people know in the guys area management course we tried to do things a little bit differently, and that's one of the beautiful aspects of RAUK 21 is it's a virtual meeting, but it's different. It's not a didactic record lecture, send lecture, watch lecture, get a certificate. It's a much more interactive way of delivering educational information with some of the world's best experts. So I think that's one of the really exciting things about RAUK that would be a real big selling point for people to join. Not to listen to me, but to listen to actually some really great speakers having a great conversation.
Obviously, you're being very modest there, but what's really fascinating about your involvement with the meeting is it kind of covers very beautifully that transition from regional anesthesia to point of care ultrasound. I know you, Rosie, Johnny, Steve, and Chris have got an exciting a major trauma POCUS symposium planned, but we're also going to see you participate in some symposia talking about other aspects of regional anesthesia, and we can't forget your academic background. You're also going to be talking on the second day about some papers that are influential or made people think about regional anesthesia. That's going to be really exciting. So to close up this short discussion, Kariem, I'm going to ask you the question I've been asking everybody else. So if you had to pick your favorite upper limb, lower limb, and trunk blocks, what would they be and why?
Upper limb, hands down, easily for me personally, it's going to be an infraclav. Love it. It's reproducible. It's a reliable block. You get a dense block. You don't have to poke around. Don't have to chase four different nerves. Don't have to worry about getting the plexus sitting on top of that rib and not worried about a pneumothorax. And you don't need to worry so much about the phrenic nerve. Infraclav, hands down.
Okay, quick
Um,
point of
uh,
note though, should we have made that a plan A block then?
so that's why I actually started off by saying for me is the infraclav, because I'm comfortable with doing them and I've done them plenty of times. But to make it as a plan A block, you also have to factor in what is feasible, accessible, and easy to perform by the vast majority of practitioners. And I could see why this one carries potentially greater risks and potentially greater challenges for performing if you're not really comfortable with doing ultrasound guided regional anesthesia, particularly infraclass. which is
Okay,
why I think the Axe book is a quick go-to, reasonably safe, and great for learning skills. But for me as a clinician, I see a patient today that needs hand surgery, going for the InfoCloud.
perfect. What about lower limb and trunk?
Lower limb is probably going to be the popliteal block, but that's because I do lots of foot and ankle work and foot and ankle anesthesia. And for me, the other thing with the popliteal is we're using it increasingly for catheters for amputation vascular patients. I love the popliteal block because for me, it's this. I love that. I love seeing the common perineal and the tibial nerves not being touched by a needle, but being pushed apart by the local. That gives me a warm, fuzzy feeling inside.
Excellent, very nice. And lastly, a trunk block. Of all the plethora of trunk block techniques that are out there, what gets your vote?
So it's going to have to be ESP, and not because I'm deeply in love with Ki-Jin Chin, which I think the vast majority of the globe are, but because it is a really straightforward procedure to perform, and it's so versatile. It is probably the versatility of the ESP block that means it gets my vote.
Excellent. Kareem, that was extremely insightful and very enthusiastic selling for our UK21. Really look forward to seeing you at the meeting, hopefully in person as we're filming at the studio with social distancing and all that business. But I look forward to seeing you soon. Thank you so much, Kareem. Take care. Bye bye.
Cheers, Amit. Bye.